Hi guys, I am going to do a quick little video lecture on your sutures and drains, which is chapter 16, and then I'm going to do a little abbreviated review for chapter 17, which is your wound healing. So I apologize for looking like a wreck. I had a sick baby and I'm sitting outside so that I don't wake him up. So here's the deal. I know y'all haven't really had a lot of video lectures, but we're kind of getting into some stuff, and I want y'all to definitely at least hear my voice. I may say a couple of little tips or things that you've kind of kicked out over time, because we haven't talked about wound healing and any of that in a really long time. So some of the things I want to go ahead and start with is your sutures. Sutures, basic review terms, all of that stuff, because I feel like most of y'all do have trouble with suture. And if you just know the basics of where to use certain suture, it'll help you a lot. So you may not get tons out of this review. You may feel like I'm just kind of reading the PowerPoint, but most of what I've put on this PowerPoint is important information. So some of your review terms: Dermabond. Y'all have all probably used Dermabond in a surgery at some point by now. The important part is that you know the other technical term for Dermabond, because when you take your board, sometimes they use that word to try to throw you off. So cyanoacrylate is the technical term for Dermabond. Everybody calls it Dermabond though. You also have what is called collodion, which I put on here is just another fancy word for a liquid Band-Aid. You can actually buy something that's very similar to this at Walmart. So the collodion can be applied with like Q-tips, things like that. It's really just to create a sealed layer over something. Another review term that I want to talk about is tensile strength. So that is going to refer back to our sutures, of course. So like when you can pull and how much strength that suture has, that is that tensile strength that you're looking for. Fibrin glue, that's really dependent on the surgery. It's pretty expensive. So most of the time you'll see that in like cardiovascular or plastics. Very specialized cases will use fibrin glue. When you think about fibrin, think about that tissue healing that we talk about. You know, you have your surge of fibrin to like an abrased area. So that's it's pretty interesting if you want to kind of look into that. But definitely seen in more specialized cases. Suture boots. Okay, so if you have done cardiovascular cases, you know what those are. So if you look over to the right on this PowerPoint, you will see these little green, a lot of times they'll call them shods. So they actually will put those little plastic rubber boots on the end of your stat so that it's not crushing down on a vessel, or it is not damaging your suture in any way. Because anytime you put a mosquito or any kind of hemostat on that suture, it is damaging it. So by using these suture boots in vascular, cardiac, whatever, anytime you're working with those really delicate sutures, you don't want to fray them, because then it's not going to be able to hold up as well when you are tying it off and passing it through. So that's really cool. I will tell you, a lot of times you can even use this in plastics because they do use very delicate suture. Some Plastic surgeons do not want to waste and have extra costs, so they get very creative. But if you are like a quick thinker and you know that that's something that'll stress your surgeon out, if their suture's messed up, always ask. It never hurts to ask. Umbilical tape. Once again, if you have done cardiovascular, you have seen this a lot. They will use this to almost work as a retractor for vessels. They can loop it through, pull things over without putting a lot of tension on it. Umbilical tape will always come in like a pink and white container, so pay attention to that. You'll see it in OB cases, cardiovascular cases. You can use it pretty much anywhere if the surgeon feels creative, but those are the main ones. I want to remind you, Halstead is the man with the plan. He's the one that developed the principles of suture techniques and how to handle them delicately so that you're not causing a lot of issues, and how you handle the tissue better. So you'll always hear people say, oppose, not necrose. So when you are opposing and bringing that tissue together, you want it nice and lined up. The more tension and the tighter you pull that suture, the more you're going to buckle up that skin and it will not heal. So that's where that saying comes from. Oppose, not necrose. If you're cutting off the blood supply or you're damaging that tissue, it will not heal and it's not going to be pretty. You're going to end up having to debride it, clean it up, close it again. So let's move on. Needle tops. So this is where we get into the nitty-grittiness of sutures. So when we talk about the tops, I have kind of gone through here and told you mostly where you're going to see it. Taper needles. If they say they want a taper needle, they're more than likely working inside. Okay, so inside a person, GI tract, anything like that. Okay, vessels. If they are using cutting or reverse cutting, that will almost always be for the skin because of the way it goes through. It leaves a flat, leveled incision when you bring that needle through the skin. A Keith needle, so that is just a straight needle. It can be sharp, it can be blunt, whichever. What you have to know is that a Keith needle is a straight needle. It has no curve to it. Sometimes you will see them use a blunt Keith needle on the liver. Always know that a blunt needle tip is used for liver, lungs, friable or delicate tissue. And I've kind of talked about that at the bottom here. So the French eye, a lot of those you will see in orthopedic cases because they will just be the needle, and a lot of times you'll have to load that needle with Ethibond or whatever kind of suture the surgeon's using. So with orthopedics, you may be doing a total shoulder and they're needing to mark that deltoid to know where to come back and bring it together. So you can't have a ton of needles just hanging from the deltoid. So you will actually load it up with Ethibond, which is the strand of suture, and you will go through, wrap it through the deltoid, mark it, pop the needle off. So you have a free needle. That's what you will hear it called a lot of times, a free needle. I'm going to say the majority of what you are going to use is the swaged needles, which are already connected and they're not going to pop off. So a lot of times this is just a 1-strand needle. If it is not a controlled release, this is what it is most of the time, okay? Your controlled release are your pop-offs. I will say a lot of times those come in multi-packs. It's not the exception or anything. You will still have occasional single strand sutures that will pop off. But most of the time when you are in surgery and they want a pop off, it's going to be a bigger pack so that they can constantly be suturing, popping it off, getting another one. And we've done that, so that's pretty common for y'all right now. And we've already talked about the blunt. So these are all characteristics of the needle, not the actual suture strand, okay? Next, we're going to move on to the technique of the suture. So this is really how they're going to do their closure. Those bugs are really loud. All right, so you have running or continuous. That's great if you are doing something that you're really not concerned about getting infected. So nothing sucks more than doing a running suture and it popping halfway through. You can fix it, but a lot of times if it's a newer person doing the suturing, you're just gonna start all over. And the bad thing is if it gets infected, you have to take all of it out. So running or continuous, they're starting at one end and working their way all the way down that incision. With interrupted, you're gonna have several different stitches to where they are throwing a stitch, tying it off, cutting it, going to another one, tying it off, cutting it. The good thing about interrupted is if it does get infected, you only have to open up a couple to clean out the infected area. Then you can close it back up eventually. The downfall is it does take a little more time. It really depends on where you're working, how tough the closure is on what your surgeon prefers to do. Sub-Q. Most of the time your sub-Q is used before they get to their running or interrupted suture. I will tell you, sub-Q is the go-to standard if you're working anywhere on the face or anywhere that will be seen to just anyone. Even if it's the arm, you know, the legs, they really try to make it look nice. And that's why they do it, because it really gives the best cosmetic closure. You don't have those little scars of where you've gone back and forth across the top of the skin because it's in that subcuticular layer. Let's see. Purse string. So purse string can be used, of course. Everyone talks about the appendiceal stump. Once you do an appendectomy, they invert the stump, close the cecum with the purse string. So if any of you women out there have ever had one of those sack purses or those backpacks, guys, where you just pull the drawstrings and it closes, that's the concept of a purse string. You can use that for any kind of circular or tubular closure, but the appendiceal stump is the most common. Couple of things. So retention suture. Retention and bolster. I like to use these because a lot of times you're going to start to see more obese or larger patients. So by using retention sutures, and they don't necessarily have to be larger patients, it just depends on where the closure is. If it's the abdomen, or if it's an area where they're going to have a lot of flexion, you really do need to consider using retention or bolsters, because it helps to kind of reinforce that. So retention, it's holding it together without cutting into the skin or without it pulling apart easy. So when you use retention, it needs to be a larger suture. And what I mean by that is like the gauge. The suture itself needs to be thicker, because when you have a big mass and you're trying to close it, you don't need to use like a 4-0 or a 5-0 suture. You need like a 0, 1, you know, it needs to get larger on the scale. A lot of times you will see ortho doctors use mattress sutures. It's good to use. It's one of those things that takes a lot of time. But once again, it kind of has the same concept as retention sutures. By doubling up on the mattress and going back and forth, it's bringing that closure together easier and eliminating the surface tension. So I like it. It does take a while, so it's not like my favorite thing to use. Lastly, we'll talk about the extracorporeal. So this is referring to something that is outside of the body, okay? Corporal. So if it is intra, it's inside. So most of the time what happens and how they do this is if they're doing like a laparoscopic bowel resection or something, they will actually do their procedure inside, but whenever it comes time to tie the knot, they will do it outside of the body. Or they can even go ahead and make their loop and place it in, and they'll use what's called a pusher and push it through the laparoscopic port to seal that down. So that's pretty cool. Let's see, moving on. Okay, now we are going to talk about the suture strands themselves and whether it's absorbable or non-absorbable. So here's the deal. You're not gonna know all this as soon as you get out, so don't freak out, okay? It takes a little bit of time and practice. The main thing to know about is which one is going to break down. The most common ones that will be absorbed in the body that you're going to use, monocryl and bicryl. If you know that, you're golden, okay? Any of the guts are going to be absorbable, okay? When it comes to non-absorbable, this is your silk, nylon, proline. So how can you remember that? Remember it by where you're going to use it. So silk is used on the GI tract. If you're ever in a general surgery and you are tying off bowel, you're going to use a silk, okay? If you are doing anything, let's say in orthopedics, they're going to be using a nylon, stainless steel, or Gore-Tex because they're really wanting something to hold together, okay? Nylon can also be used in cardiovascular and neuro. Proline or polypropylene, non-absorbable because where are you going to use it? Vessels, right? Proline can be used on vessels, and you definitely do not want that to dissolve and then you have nothing holding your vessels together, okay? So heart surgery, proline, okay? Stainless steel, you obviously know that's not going to go anywhere. That's going to be the one that they use for bone fixation. Okay, so think about the sternum, bringing that sternum back together. They're going to use stainless steel because it's less likely to harbor any kind of infection. So it's the most inert, but it is the hardest to work with because it's very hard to get that to bend and wrap the way you want it to. And even if you do get it the way you want it to, you're going to have to fold it down so that it's not rubbing against anything, okay? And then the last one is that polyethylene or that Ethibond that I was talking about earlier. That's polyester based, okay? That is your go-to orthopedic stuff. That's what I was saying with that French eye. They'll load Ethibond onto that. It's very tight, it has a good tensile strength, so they know that it's not going to start to fray, okay? So non-absorbable and absorbables. So why is monocryl and bicryl part of that absorbable? Because monocryl, a majority of the time, is used where? Face, superficial areas, right? Okay, they don't want you to have to worry about that being there forever. It's going to dissolve over a majority of weeks, okay? Bicryl, also known as polygalactin, that's important because that will show up on your boards. They will try to trick you and say polygalactin instead of just bicryl, okay? They like to be complicated. Bicryl is used a lot of times for that fatty closure, right? So say you're doing a general surgery case and you're closing up, you are going to start with your non-absorbable at the muscle layer. You're working your way back to the skin. You get to that fatty area, that sub-Q. That's where you get the bicryl. Then as you go up, you're going to do that monocryl. And they want those top two layers to kind of dissolve over time, and everything underneath that needs to stay where it's at is going to be using a non-absorbable suture, okay? I hope that helps. I hope this is not making it way more confusing. The next slide, I feel like it really helped me whenever I was learning. It shows the difference in the sutures. So silk, of course, is a braided suture. It's non-absorbable. You have that polyester, which is Ethibond, okay? Polygalactin 910 is what? Bicryl, okay? That is a braided, absorbable suture, okay? Polypropylene, which is your Prolene, is a non-absorbable monofilament, because if you look at this, you'll see it's one single strand. Monofilament is like fishing line, remember? Okay? Multifilament is your braided. So nylon, non-absorbable, monofilament. Okay? And then you have your nice little monocryl. I added that nice little monocryl over to the side, and that is absorbable. Okay, I hope that helps as a refresher. Let's go ahead and move on to drain. So this is one of my favorite things. I really wanted to do these chapters because I love talking about this kind of stuff. So drains. When it comes to drains, you have so many different types. When you really sit down and think about it, though, you have a passive category and an active category. So passive, you're just letting it flow through, do its thing. So a Penrose drain, right here is an example of a Penrose drain. It does have packing in it, but we'll talk about that in a second. I'm sure y'all probably remember, but just in case you don't, this is a refresher. So passive. A lot of times, if you do a bowel, sorry, not a bowel resection, a breast reduction, If they do not need tons of evacuation of blood, they will just place pin roses underneath and bring them out the incision to let them drain for a day or two. And then they pull that out and close it up. So it is just passively oozing out on its own. Sometimes if they have a very big cyst, they will place a pin rose to let it continue to drain out so that if they close it up, it doesn't have an infection again. One thing that you can do that I think is really cool and fun is make a cigarette drain. Some people don't do this anymore because it's kind of, people don't even think about it. It's like one of those outdated things, but I love to do it because I feel like it works very well. Cigarette drain. So you take a 4x4 and you undo it, pack it through that pin rose drain, and it works by wicking. So it is taking the ooziness and it draws it into that gauze, that 4x4, and it's actually pulling it out to the other end. So as it soaks up, it continues to soak down that tube. I think it's really cool. I feel like it works very well. So if you're ever in a pinch and you're with a surgeon and they are trying to figure out what to do, that's always a really cool thing to bring up for them. Give them the option. Say, would you like me to make a cigarette drain? If they have no idea or they haven't heard that in forever, you look like a rock star. I love them. Another one is your T-tubes. So where are T-tubes commonly used? The gallbladder, right? That is a passive drain to help that bile come out without having to open everything up. You don't want to use an active drain because once you use an active drain, you are pulling as much as you possibly can out. And that's not super healthy right there. So you want to use a T-tube where it has very passive drainage so that the bile can just slowly come out on its own. Any stones that are in there can pass through. So that's your main go-to. Remember, T-tubes are for common bile duct, gallbladder, the biliary tree, that kind of stuff, to help passively drain bile. Your active drain, so this is where you get your hemovac, or a lot of times you'll hear it called the hamburger drain. That's that rounded drain that you will compress, close the tube, and it will suction. It will pull all of that fluid and blood and anything in there out. Okay? That is an active drain because it's actively sucking all that away. Okay? Your Jackson Pratt, if y'all remember, we kind of call that a grenade. Looks like a little handheld grenade. You squeeze it, close the cap, and once it's hooked up to suction, it will start to pull it out. So each one of these, what I want you to know, when it comes to an active drain, there will always be levels that show how much fluid is coming out. Depending on the surgery, it's very important to monitor how much blood and anything that is coming from that wound. You need to measure it, okay? Because if it's filling up very, very quickly with blood, you probably have an active bleeder somewhere. That's a very good tech tip. Be conscious of the wound healing, control, drains, all of that. I'm very weird about how good your wound closure is and how healthy how active, let's say that, how active you are on monitoring where those drains are going and how they're filling up. Next, you have a striker drain. those aren't used as much as they used to be. Those are pretty big and bulky. They used to be used for total knees and hips because they could really draw out a lot of fluid, but now most surgeons are just using the Hemovac, the hamburger drain. And then you have Pleurovac. Pleura should make you think of lungs, right? Pleural space. So Pleurovac, the important thing to know about that, it is considered a water seal drain. They have to have this to keep what is called negative pressure, okay? We've talked about that, how this space right here, without that pressure, you're not able to expand your lungs and to be able to breathe, right? We gave the analogy of like a balloon and pushing in on a balloon. So if you don't have that, then they can't fill up and release, okay? So you have to have what is a negative pressure on the lungs, okay? So very important when you have patients that have gunshots, open, any kind of opening at the diaphragm, the thorax, anything above here, they're going to have a chest tube and a Pleurovac system. If they have had cardiovascular surgery, they're going to have a Pleurovac, okay? Chest tubes are not fun. If you become an assistant and you help pull them out, I pray for you. All right, moving on. So let's talk about your biopsy needles. In this chapter, it talks about a bunch of different biopsy needles. So I came in, I put what it's used for, because that's going to help you. When I took my test, I was like, I don't know. I have no idea. I knew what a true cut was, but I did not know what a Dorsey was. So Dorsey needles are for brain tissue. Now they kind of have some different options, but we're strictly going to go by what's in this chapter right now, because these are the kind of things that you may see on your boards. A Sheba is used for lung biopsies. The True Cut and the Franklin Silverman. True Cut is probably the one. True Cut and Dorsey are probably going to be the two main ones that they ask you questions about. True Cut is for the liver. Over to the right, I've kind of given you an idea of how this works. And some of you, I'm sure, probably already knew this. But if you didn't, I wanted to go over it again. Because when I first started as a student, I was like, how the heck do you do a biopsy? Because you hear needle biopsy all the time. Or aspiration biopsy. And I thought, you just stick a needle in there and suck it out. So with these specialty biopsy needles, if you look over here, you will see that they will have the pointy tip that goes in, like a regular beveled needle, okay? Some of them will be flat. Some of them, if they're aspiration, they already have an opening, okay? But it goes in. Once the needle is in the tissue that it needs to be in, they will slide what's called the sheath back, and you'll see this little opening inside the needle. And it's very sharp in there, and so when they close that sheath back, it's actually cutting out a piece of that tissue. So at that point, the tissue that is being biopsied is inside the needle. The sheath is closed over it, and they're able to draw it back out. And then they can send it to pathology to be checked. Okay? I hope this review helps you a little bit. If you have questions, please let me know. Okay? All right, now we're going to move on to chapter 17. See you in just a minute.